Dr. McCurdy, it is an absolute pleasure to meet you here in Wilmont Gardens at the University of Florida. And you've been here for a couple of years doing research. Really excited. Thanks so much for joining.
Well, thank you for having me.
So, you have been researching really what so many people in this country are suffering and dealing with, and that's the sort of intersection of where pain and addiction meet.
That's right.
Tell us a little bit about it.
That's right. So, we've spent a lot of years in my laboratories studying pain, trying to come up with new ways to treat pain, not just the opioid means that everyone has been using for years and years and years, but trying to come up with maybe some non-addictive ways to treat pain, but also realizing the power of the opiate system and understanding that it's really difficult to try and compete with that level of pain relief that opiates can give. And so trying to find alternatives that not only interact with the opiate system, but maybe interact with other systems that can counteract some of the effects or the addictive or abuse liabilities associated with those. So we've been looking at those areas, and then that sort of falls right into the addiction area as well, and looking at ways that we can try to treat those that are addicted, try to alleviate some of that disease and help them return to more productive quality of life. So it's not just in opiates. We've focused also on psychostimulants in my laboratory over the years. So we've looked at treatments for cocaine and methamphetamine as well, which there are still no approved treatments for those two drugs. Of course, we have some treatments for opiate addiction, but they're, again, opiates themselves, right. And they tend to be more of a replacement or a step-down type therapy than something that really can move people off and away from those medications.
When you talk about pain, from your experience and the research that you've done, how do you define pain, and really curious about sort of like the definition of pain?
Yeah, I think it's a really difficult thing because pain can be many things. Of course, there's the acute pain that we can experience if we slam a finger in a car door or we get burnt on the stove, something like that. But then there's emotional pain, and how do we even focus or think about emotional pain and treating that emotional pain? And then there's visceral pain, so just this really deep-seated pain inside our bodies, organ pain, those types of things that can be extremely difficult to pinpoint and treat. And so pain is really, as far as a definition goes, it's almost impossible in my mind to define it, because there's so many different ways that our body can experience pain. It's really tough. And I think this has been a really big challenge in research for us to try to understand how do we treat that pain.
Right.
And we've been studying pain models in animals for the same ways for really decades, and it's not a surprise to me that we haven't been able to move that treatment paradigm forward, because we just can't find anything better than what we already have. We can find different ways to try and approach this, but we're still treating our studies the same way we have for decades, and really trying to move away from what is really an acute pain measurement. So the way we test pain medications is really just the way I described earlier. If it's too hot, we try to extend that animal's interaction with heat. So we put them on a hot plate, which is exactly what it sounds like, what you might put your cup of coffee on to keep it warm. But those animals will go on a hot plate for a defined amount of time, usually within a second or two. Without any drug treatment, they're already starting to lick their paws, and you can remove them. And then if we give them something like morphine, they'll stay on that plate till the time point that we cut them off, where we don't cause any tissue damage. We protect the animal really well.
Yeah.
But this is really reflexive measures of pain. So you're experiencing something, the brain sort of realizes there's a painful stimulus input, and then the body reacts to that by, in this case, they'll lick their paws to cool them down. There's another way we do it, which is, it's called a warm water tail flick, where you actually put animal's tail, mouse or rat's tail, into warm water bath, and they'll withdraw it out of that water bath after a second or two. And then we can do the same thing. We can look and see if we can extend that time frame that they interact with that water, by giving them something like morphine or any other drug to see if we can enhance that timeline. So those are the real main ways that we study trying to find new pain medications. And so we're not looking at, and we don't have really good models of chronic pain, of what we see in actual humans that have been suffering from, maybe sciatica or complex regional pain syndrome, for which there's still no real good diagnostic tests. There's really difficulty in us trying to model the real human pain conditions in an animal and then try and study that with new drug treatments. And so to me, it's not a surprise that as researchers, we've been stuck in a rut for the last 50 years or so, and we haven't seen new pain medications really coming out.
That's very interesting. So you're saying, because we're not able to emulate some of the animal models around pain, we've been in this rut for these 50 years. And I think, to your point, I'm really excited to continue the conversation around, where pain management goes and how it intersects with addiction. But when you think about pain, and, I've grown up hearing, someone has a high pain threshold, someone else has a low pain threshold. Can we build a resilient, are we able to become stronger and more resilient to certain pain? How does that change in our lives?
Yeah, I don't know if you can sort of teach yourself to become more, tolerant of pain.
Right.
You probably can. I mean, as people go on through life, they will push further and further and harder. And they'll, if it doesn't kill you, it makes you stronger statements.
Right.
But pain is a very subjective thing. So, in fact, when you go into the hospital or you go to see the medical team, they'll ask you what's your pain level on a scale of 1 to 10. Well, 10 for you may be 5 for me, or vice versa. And there's no real way to say the pain you're experiencing is different from the pain I'm experiencing, but we perceive it as something very different. Every single individual does. Now, how does that change over time? I don't know. It's interesting because, considering that pain is supposed to be the 5th vital sign now, it's the only vital sign that we don't have an objective way to measure.
Okay, say that again.
So pain is the 5th vital sign. That's counted. So if you were to be checked into an emergency room, or you go to see the doctor, the physician will ask you, how's your pain level today? Where do you feel on the scale of 1 to 10? And then they'll give you some facial recognitions of what should be a 1. You're kind of happy, no problem, versus a 10 where you would be in very excruciating pain, tears, and just can't stand yourself. But this is now recognized as the 5th vital sign, and it's the only one we don't have a way to objectify. So we can take blood pressure. That's very straightforward. We can take temperature. It's very straightforward. So all these vital signs that we have been used to recording and making sure we can keep track of, and we can really watch how those vital signs are changing in response to drug treatment or just lifestyle enhancements. Pain is not one of those. So it's really a difficult one, and then you really have to trust the person that's telling you, today I'm a 5, or today I'm an 8, or today I'm a 10. And I think it's really a difficult position to be in, especially for physicians. And then physicians end up in sort of a catch-22 place where they want to treat the patient, help the patient get out of this pain, And then, I think we end up sort of in the situation that we're at today with the opioid crisis, because we've sort of gone to the extreme of over-prescribing, trying to keep everyone comfortable, trying to keep everyone out of pain. And why are we, as a country, so much in pain?
Right.
That's a whole nother question. And I think it's something that I can't answer. But again, it comes back to all those different types of pain, not just the acute pain or the chronic pain, but those types of pain. And then as we try to move forward and understand this better, we really have to adapt our research efforts. We really have to start looking at animals that are in chronic diseases that cause chronic pain. So one thing that's very common is diabetic neuropathy. So lots of diabetic patients, their nerves will start to die off, and they will start to get very painful feet and hands and limbs. And we don't have a good way to try and model this in an animal. We do have animals that spontaneously develop diabetes and will go on to progress to something like diabetic neuropathy. But then there's just so much variability in the animals, and there's so much difficulty in trying to understand that. We have other neuropathies that can be induced by chemotherapeutic agents. Those we can model fairly decently in animals now, because we can actually cause the nerves to be damaged by constant treatment with chemotherapeutic agents. We also have the same thing with HIV treatment. So some of the heart therapies, the highly active antiretroviral therapies, are causing neuropathies. About 90% or so of those patients that are being treated with the HIV cocktails develop neuropathies as well. And so these are really things that happen over a period of time. It's not just that acute injury from a broken bone or something like a tooth extraction.
Right.
This is something that's developing much different type of pain. And then we have these visceral pains that are, I don't really know how we're ever going to develop good animal models to understand that. And visceral pain can be even more difficult because it can be a referred pain. So you can actually have something wrong with a kidney, but you feel it in your upper back or your shoulder or something very strange. And so that can be misleading in terms of trying to get to diagnosis and trying to understand what's going on. How do we model those in animals? It's really difficult because animals can't talk to us either.
Right. And it's so interesting when you're talking about the visceral pain. I was, just reading the other day how for women with heart disease or a heart attack that may be coming, the symptoms are not what we would sort of say are the classic symptoms. So it can be anxiety, it can be restlessness, it can be, not being able to sleep a lot, fatigue, these sort of things that you wouldn't necessarily associate, which maybe, relate more to different types of maybe pain or, emotional pain, or you think they're being triggered by emotional pain, things like that. Very confusing.
Very
very
stress
confusing.
plays a huge role into all of that as well. And stress plays a huge role into pain. And that's another component that we're faced with and actually challenged with in animal research. Because when you handle an animal, it causes a stress response in that animal. So they're releasing cortisol, they're releasing other types of endogenous compounds that can interfere with the studies that we're trying to do and trying to come up with new drug interventions for treating pain. So it can all get really complicated in a real
absolutely.
hurry.
So stress and pain for us, we're releasing that cortisol. How does that work?
Yeah, I'm not really sure on that whole level, but I know it causes heightened sensitivity to pains. You can also get inflammation. More inflammation starts to add more to those pain, and then the mediators of inflammation that get released in the body, all that sort of ramping up inside our system. There's this sort of internal war going on with all these chemicals, trying to handle the stress, trying to handle the inflammation, and what the end result is this sort of not good feeling, painful feeling, and then how do we combat those things?
Fascinating.
It's very, very challenging, and everybody is different.
Yeah, absolutely. With we're going to get into some of the natural compounds. We're going to get into addiction. But if you were to, based on your research, give us a couple of ways that we can, with our own body, without ingesting anything, help to work with different types of pain, what would your 1, 2, 3 top?
Yeah, so it's a great question because I have chronic pain myself.
You do?
And being a pharmacist and being a trained pharmaceutical scientist as well, so I got my pharmacy degree, have my license to practice pharmacy, then went on to graduate school and got a PhD in medicinal chemistry and drug design. I'm not one that likes to take drugs.
Yeah.
So it's kind of ironic that I try to find new drugs to help people. But I suffer from sciatica, I suffer from a lot of my own chronic pain. And the way that I've found to treat it is really diet changes that can really help with reducing those inflammatory markers in your body. So eating more, at least for me, more pure, unprocessed foods, more clean vegetables and fruits and meats that haven't been treated with a lot of chemical preservatives, especially because preservatives are not only enhancing that meat for lasting longer, but they're also going to give problems for us down the road ingesting them. So really eating a good diet. I do a lot of exercise, personal trainer to help strengthen a lot of those muscles that normally you wouldn't be using, but having that extra support, those support muscles, those other things that you don't even realize they're there until you start using them.
I do the same thing, and I love it. The strength and conditioning and postural work.
It really, really helps. And it's amazing because before I started that, every morning it was a struggle to get out of the bed because of back pain and hip pain. And after getting in with a trainer for several months and strengthening a lot of those secondary muscles or support muscles, I don't wake up with pain anymore. I'm able to do that. And that combined with, I think, more healthy eating, a lot more fish, a lot more chicken, a lot more of that kind of meat. I still love my steak though, so I still have my steaks. But just really focusing in that area. Then I do deep tissue therapeutic massage as well, which has been really incredibly helpful for me with getting a lot of those muscles loosened up and moved around and adjusted. I don't do chiropractor, but therapeutic massage for a couple hours every 10 days or 2 weeks is really helped me. So those are the natural things I do. I tend not to want to take medications. This is a joke of pharmacists is drugs are to sell, not to take. So, and that's bad. but that's kind of the joke. And that's where I go. I mean, when I have to, I'll resort to taking medication, and it works, and it's great. But I try and avoid it as much as I can.
That's awesome. Very inspiring. Thank you so much, Dr. Chris.
Thank you.